a patient have a first rib resection in the main OR and die, a 17-year-old. Okay, and the circumstances were, I don't have to go into all the details, but there wasn't thinking about worst case scenario. You should always be asking yourself, what is my worst case scenario and how do I deal with it? And in fact, Bassem, I think that it's important that we, that, and I said before, I thought it would be great, mainly in arthroplasty, if we had somebody give a teaching tutorial on what to do if you have bleeding, which we've talked about before. But every single surgeon who does a shoulder replacement where there can be an axillary artery injury or something like that needs to know how to manage that. Yeah. And I don't think that that's all the case. Now, in this instance, it's even more proximal. You'll manage nothing if the subclavian vessel is damaged. That's audible bleeding, and you can't control that. So again, even if it's half of a percent, if you do enough, eventually your luck runs out, and so does the patient's. Okay.
So I'm gonna just present this one quickly, and hopefully we'll close up with this one. This is mostly because a lot of our visitors, they like scapula for whatever reason. So this is a 53-year-old, but again, this is not straightforward. When I'm presenting it, it's not, we have a lot of cases, but it's not straightforward. So this patient had lymph node biopsies, a true spinal accessory nerve injury by EMG and exam, and she has trapezius paralysis. She underwent quote-unquote triple tendon transfer by myself, but like one of the surgeons around in the New England area, not necessarily my general. And the patient was progressing okay, but then she started to regress and she did not feel like she was doing very, very well. So referred to us for ST fusion, because usually if the triple transfer failed, truly like the salvage will be ST fusion. So I'm gonna show you her exam. I'm not gonna show, like, this is her, okay? With the flexion, you can see. I'm gonna put her in flex position. So Jimmy, so far, from this exam, what do you think she has? How's her serratus?
I think it looks functional.
Okay. But like in the beginning of the year, before you start to do the SFRT, if you look at specifically this.
Sorry. I was saying it looks functional, looks like it's okay.
Yeah, but if you look at this exam, the wall push-up test, what would you say? I think there's a.
I was saying it looks like she's a functional serratus.
All right, Kevin. If you look at this wall push-up test, what would you say? This is a functional serratus or not?
Probably not.
Okay. What about now?
Yeah, I mean, negative at 90, 100 there, so it's not paralyzed, but it's hypoactive.
Yeah. So this is why we don't use the wall push-up test anymore. Because if you look at it, this look a typical serratus paralysis. Look at this one. But when we do our SFRT, the patient is negative at 100. So her serratus is normal. When I stabilize her scapula on the chest wall, she did better. And now this is scapular repositioning. She did much better. So in terms of what I noticed though, like right now, I'm trying to stabilize her. She did not get fully better. Let's do it again. Sorry, this is important. So SFRT is negative at 100. It means serratus is normal. Okay. Now, if you stabilize the scapula on the chest wall, and abduction, she's slightly weak. The scapula is prominent. If you stabilize scapula on the chest wall, she should get better. I'm trying now. I'm pre-positioning it. Go for it. Her abduction did not improve as much. And when I try to do scapular compression test, she should like fly up. She was like flexing slowly, but not completely. She was fighting me. So Sally, what would you rate this one? What stem this one is?
Stem 2B.
Stem 2B.
Yeah.
So well, this is very important, by the way, because when I tried to reposition the scapula on the chest wall, the tip of the scapula, she gets slightly better, but she was still fighting it. So this patient is very tricky. This is a combination of a functional problem and a structural problem. Like structural problem in terms of the trapezius, the triple transfer that was done, she has some laxity with the drooping of the scapula. But most of what she has is functional problem. This is why, if you notice, she started to do well and then she regressed. So she has a combination of functional and structural. This is very, very tricky. So she would not need an ST fusion, in my opinion. So this is what we did for her. We exposed the serratus. Serratus is normal. That's the serratus, is normal. So in her case, I was debating whether or not to do a sexy pexy, which she already had pectoral spinal release, or shall we do a serratus advancement to essentially help protracting her scapula on the chest wall? And we decided to do a serratus advancement in her case. Because I was worried she's gonna break her rib because she had really a very abnormal functional problem. So with the serratus advancement is essentially local transfer of the serratus. So what we do, we detach the distal serratus and we advance proximally. It will look like a proximal advancement. And this is what we did for her in this case. And you notice there's an incision here, and I tried to advance. She did have an upper trapezius, by the way. So probably her original problem was all functional and some part of it structural. So I did advance her part of the upper trapezius. So this is like the distal scapula right now. The serratus was here. We're gonna advance it around 2 centimeters. So this is the debridement of the distal aspect of the scapula. And these are the drill hole we did them. 5. You saw this one yesterday, guys, like the loop sutures with the use of Dynacord.
Mm-hmm.
And then we're gonna try to pass all the sutures around the bony insertion of the serratus to try to advance it proximally. And now the serratus went from here up. So the serratus insertion was here, it went proximal now. And now when you stimulate, you're gonna see the difference. Like it's gonna essentially, look, the power of it become much stronger and advance the trapezius. So these are the acromial, the endobutton from the trapezius advancement. She's 9 months post-op, SSV 95, very happy and thankful. Look at her shoulder. She's aligned. I just advanced her trapezius and advanced her serratus. And this reflection. Exam, very important. Mechanics is very important, and try to do like the right surgery for the patient. I would not have been able to do the ST fusion, they do well, but it will not give me this good of a function of the patient. And she's now almost 2 years. She sent me a message recently. She's dealing with other medical problem. She's very happy. She feels her shoulder is close to 100%. So I thought, like, again, this is a continuation of the STEM kind of talk. I thought to share this case because, again, and I'm even the fellows, they suck, but I think they're doing a nice job understanding the STEM very well and trying to categorize what's functional, what's structural, and what needs to be done for every patient to give them the best outcome possible. Any question? Okay. And it's 6 o'clock for GP. GP, what time will be for you? 6 p.m. Would it be?
6 a.m.
6 a.m. Good morning. All right. All right. We'll see you next week.
Night.
Everyone.
Take care.
Cheers. Bye-bye.